Demonstrating on ultrasound scanning of the median and the ulnar nerves.
So thank you for the invitation. We will start with the ulnar nerve. So if you are starting with musculoskeletal sonography, I suggest that you find the ulnar nerve at the place where, at the anatomical landmark, which is most easily found. And this anatomical landmark is the capital tunnel. The capital tunnel is very characteristic. Everyone can find it, even if we are inexperienced. So the way to do it, we palpate the olecranon and we palpate the medial epicondyle, okay? So between the olecranon and the medial epicondyle, there is a tunnel which is called capital tunnel, and this is where we find the ulnar nerve. So what we do, we put a large amount of gel in our probe or in this area, and we put our probe exactly between these two bony landmarks, okay? So we put our probe between these two bony landmarks, and here we have the medial epicondyle, and we expect to see our ulnar nerve just next to the medial epicondyle, okay? You see here the ulnar nerve, and at this level, the ulnar nerve is stabilized in the entrance of the capital tunnel by a ligament which is called Osborn retinaculum. So the Osborn retinaculum is lying exactly at this area here. It is an echogenic line lying on top of the nerve. And also we might have some part of the triceps muscle extending into the entrance of the capital tunnel. So at this level, the presence of Osborn retinaculum is very important, because if you have the Osborn retinaculum, this stops the ulnar nerve from subluxating. So at this level, the ulnar nerve is this structure here. At this level, the ulnar nerve might have many different appearances. You can have a nerve which is ovoid, as in this case, and you can see this characteristic honeycomb structure, or you can have a nerve which is bilobed or trilobed or rounded. And sometimes the nerve there is so hypoechoic, normally hypoechoic, that you cannot see any fascicles inside, and it is so hypoechoic that it could even mimic a vessel. But you know, because of anatomic landmarks, that this is a nerve. So at this level, the nerve is stabilized. And if you want to check for instability of the nerve, if you want to check whether the nerve is unstable and moves outside of the capital tunnel, you take the patient's hand like that, you take the patient's arm, you ask the patient not to move the arm at all, we move the arm for them, and we ask them to perform flexion while stabilizing our hands like that, and extension. And in this specific person, you see that there is no instability because the nerve stays at the groove, it doesn't go outside. But you can have instability as part of normal conditions, as part of normal appearance. The trick I suggest to test for instability is that you hold your probe with your 3 fingers like that. We hold the probe, this is the 3-finger technique of holding the probe. So you hold the probe with 3 fingers as if you're holding a pencil with your right hand. The 2 fingers rest against the patient's arm, and that helps you stabilize yourself. And your elbow holds against the bed. So what you do here is that you stabilize yourself like that. You don't press the nerve, because sometimes by just pressing the nerve, you subluxate the nerve. You might move it around. So you try not to press a lot. You press on the 2 fingers on the patient, and these 3 fingers have a very light grip on the transducer. and then you extend like that, and you flex like that. Now, sometimes you might listen to a little tap. So you might see a structure bumping together with a nerve on top of the middle epicondyle, and this is the medial head of triceps. Sometimes the medial head of triceps has a very low-lying insertion. It goes down, and it subluxates together with the ulnar nerve, or without the ulnar nerve, just only the triceps, medial head of triceps. And this is called snapping triceps, and it can be a cause of impingement. So this is the entrance of the capital tunnel underneath the Osborn retinaculum. And when you move more distally, you see that the nerve goes inside the true cubital tunnel. Now, the true cubital tunnel is between the two heads of the flexor carpi ulnaris. So the nerve is here in the middle. We ask the patient to put his hand down like that to stabilize. And when we move down, we see our nerve between the two heads of the flexor carpi ulnaris. So that's the nerve. We see the honeycomb structure, and we have the two heads of the flexor carpi ulnaris. On top of the head, of the nerve, there is this hyperechoic structure, linear structure. This is called arcuate ligament. And arcuate ligament is the roof of the true cubital tunnel. It is practically the continuation of the Osborn retinaculum, and it holds the nerve in its place. So this is the true cubital tunnel. So when we have cubital tunnel syndrome, what we usually see is compression of the nerve at the entrance of the tunnel. So at this level, we have a huge nerve. The normal cross-sectional area of the ulnar nerve is 8 square millimeters in most people at that level. And if you have more than 8 square millimeters, you have to suspect that there is pressure on the nerve and edema of the nerve. But because there are a lot of anthropometric differences in the sizes of the nerves, you always have to ask the patient whether they have symptoms, because they might have an ulnar nerve which is bigger, completely normal, without any symptoms. And also you need to check by comparing to the other side to see if the nerve is symmetrical. So with these two considerations into mind, we report the presence of enlargement and cubital tunnel syndrome. Sorry. So as we move forward, gradually the nerve comes to the ulnar side. Then we ask the patient to put the hand like that, and we move our probe to the ulnar side of the forearm. So you see here that our ulnar nerve here is alone without an artery. And when I move more distally, this artery comes next to the ulnar nerve. You see? This is the ulnar artery. The ulnar artery at the proximal side of the proximal area of the forearm is together with the median nerve, not together with the ulnar nerve. And as we move at the mid-level of the forearm, then the ulnar artery goes next to the ulnar nerve. So here we have our ulnar nerve together with our ulnar artery, okay? So we move more forward towards the wrist, and we see here that the nerve is next to the ulnar artery and next to a tendon. This tendon is the flexor carpi ulnaris. So the flexor carpi ulnaris tendon is just at the ulnar side of our ulnar nerve and next to the ulnar artery. At this level, we have a little branch coming out of the nerve, which is this little branch here. Oh, I'm going to take some gel. So, at this level, we have the ulnar nerve, and there is a little branch coming out of the ulnar nerve. Actually, two branches come out of the ulnar nerve just before the Guyon canal. These two branches are the dorsal and palmar cutaneous branches. So two little branches which innervate the skin. They become superficial, and they innervate the skin of the ulnar side. You see here? They innervate the skin of the ulnar side of the wrist, the palmar and the dorsal cutaneous nerve. And when we move more distally, gradually the ulnar nerve comes to get its position inside the inside the Guillon's tunnel. The Guillon's tunnel is a small tunnel situated at the ulnar side of the wrist. So here we have the ulnar nerve, we have an ulnar artery on top of it, and the veins together. Now I was pressing too much and I was closing the veins. You see here? Now I'm releasing the amount of pressure and we can see the veins, one side, one on the other side. And the nerve is here. And in the cubital tunnel, we have this bony landmark, in the Guillon's canal, we have this bony landmark here, which is the pisiform. And next to the pisiform, we have the ulnar nerve. The floor of the tunnel, the floor of the Guillon's tunnel, is the transverse ligament of the wrist. And the roof of this tunnel is the palmar carpal ligament, which is practically a continuation of the transverse ligament of the wrist. And inside this tunnel, we only have the artery, the veins, and the nerve. Sometimes we might see anatomical variations here. We might see some fibers of muscle lying on top of the tunnel, like a roof of the tunnel. And these muscle fibers, here in this specific person, we have a few fibers of that. Few, I think so, these here. And these are the accessory adductor digiti minimi muscle. In some people, this muscle is very, very big, and it forms a big bulk of muscle on top of Guillon's canal, and it can even cause pressure. But the main reason for pressure inside the Guillon's canal is ganglia, so cystic lesions from the wrist, which extend inside the Guillon's canal and create pressure. And also we might have fibrous bands or small muscle fibers which occupy the Guillon's canal, and they cause pressure and impingement on the nerve. There are a lot of variations in the cubital tunnel of these structures, fibrous bands and muscles. The nerve inside the Guillon's canal at a later stage bifurcates. So here, if we follow the nerve, which these are the fibers of the nerve, you see again the vascular, the characteristic honeycomb appearance. If we follow, we'll see that the nerve at a more distal level at Guillon's canal, it creates two branches. You see here the two branches opening up. One branch goes superficially to become the superficial sensory branch, and the other branch goes deep, and it is the motor branch. Here is the motor branch, and the motor branch goes deep inside the paisohamate hiatus, which is a very narrow passageway between the hamate hook and the paisoid bone and the pisiform, and it goes through this passageway, and at this passageway it can be compressed. And this is a motor branch. And the motor branch goes down to innervate the interosseous muscles and the muscles of the thenar. So this is the anatomy of the ulnar nerve. The clinically oriented anatomy of the ulnar nerve, which is important for nerve entrapment syndromes. Now let's go to the median nerve. For the median nerve, the easiest way, if you are again inexperienced in scanning nerves, or if you want to start with scanning nerves, you need to find the median nerve at an easy place, and place which is very characteristic, which again, it is the carpal tunnel. So here, we put our probe on the crease of the wrist, okay, where the carpal tunnel lies. And we expect to see this very characteristic appearance. This appearance is the entrance of the carpal tunnel. And we have here the pisiform bone with the Guillon's canal lying here. We have the scaphoid bone here with the flexor carpi radialis on top of it. And then we have the median nerve sitting just underneath this structure, which looks like a bridge, and this structure is the transverse ligament or the flexor retinaculum. We have two ways to say it. So this is the normal appearance, and the most superficial structure under the flexor retinaculum is the median nerve, which is this nerve here. There is a structure on top of the, here, on top of the transverse ligament, and this is palmaris longus tendon. Be careful not to mix the palmaris longus tendon with the median nerve, because the median nerve is underneath the transverse ligament, the palmaris longus is on top of the transverse ligament, okay? So here's the median nerve, and inside the carpal tunnel, we expect to find 9 tendons. We have the superficial tendons of the fingers and the deep tendons of the fingers, and we also have the flexor pollicis longus. So if we ask the patient to move their fingers like that, you see that there is movement inside the carpal tunnel because the tendons move and they move the nerve. And here you see the normal movement. We have to point out that nerves are mobile structures. Normally, when we move the fingers, we expect to see movement of the nerve. And there is a lot of variation in the way people, the nerves move. Sometimes the nerves, usually they glide from one side to the other, like here. But in some cases, you might see the nerve merging inside and between the flexor tendons and even underneath the flexor tendons, only by movement. So this is completely normal. At this level, this is the entrance of the tunnel, and as we move more distally, we need to get rid of anisotropy. Every one of you knows the very bad artifact in MSK scanning, which is called anisotropy. Anisotropy is created when the X-ray, the ultrasound beam is not 90 degrees to the structure of interest. So here I have my ultrasound beam 90 degrees to the nerve and to the tendons, and that's why I can see the tendons here very, very bright. But if I tilt a little bit, the tendons become dark, and if I tilt a little bit, they become bright again. If someone is not sure what is a tendon and what is a nerve, you need to remember that the tendons are very much affected by anisotropy, whereas the nerves are less affected by anisotropy. And the reason is that the tendons are very packed with collagen fibers, so they have a lot of surfaces to reflect the sound, whereas the nerves are less packed and they have less surfaces. So here, when I create a little movement with my probe, you see that the tendons become dark and bright, whereas the nerve doesn't change so much. Huh? So if you're not experienced and you're not sure what is a nerve and what is a tendon, there are 2 ways to know. The nerve is always superficial underneath the flexor retinaculum, which is here, and the nerve, when you move, doesn't change so much by anisotropy like the tendons. So when we move more distally for our nerve, we see that the nerve gradually becomes more flat as we reach the exit of the tunnel. So here we have the entrance of the tunnel, and here, as we move, we reach the exit of the tunnel. And then here we have the exit of the tunnel with the hook of the hamate and the trapezium. And the nerve here is very flat, again, becomes flat before it gives the branches in the palm. So in the palm, here we see 3 branches for the 3 fingers. Okay? And here we have the nerve, which is flatter, because it is inside the carpal tunnel, here. At this level, when a nice trick is to take the patient's hand, like that, and you ask the patient to release the pressure on the hand, because we want to control the position of the hand ourselves. So as we scan towards the palm, we need to get rid of anisotropy and to make our nerve as evident as possible. So we take our hand of the patient and we move the hand around so that we have 90 degrees at all positions. We move both the probe and the hand in the same time to make the insonation angle 90 degrees at all times. And here we see the nerve again, creating the branches. And here we also expect to find a small branch, which is here. Look at here. All this is the median nerve. It's very, very flat because it is starting to branch. From the radial side of the branches, we see a tiny branch, which is here. that goes superficially. This is called the recurrent motor branch. The recurrent motor branch is very important because the recurrent motor branch is a motor branch that innervates the thenar muscles. And this is also called the $1 million nerve. Why? Because it is recurrent, as the word says, which means that it comes out and it goes a little bit posteriorly as in its route, and recurs, goes posteriorly, and then it goes through the transverse ligament sometimes to go out to the thenar muscles. The orthopedic surgeons are very interested in this nerve because they need to not to injure this nerve during the operations. If they injure this nerve, the patient ends up with atrophy of the thenar, which is even worse than having carpal tunnel syndrome, of course. And that's why they call it the $1 million nerve, because in the United States, they had to pay $1 million as a reimbursement for the patient. So in order to remember that, they call it like that. And this nerve, the $1 million nerve or recurrent motor branch, which you can see here, this nerve has a lot of variations. Sometimes it goes transligamentally, so it goes through the transverse ligament at a more proximal level than its origin. So that's why we need to point it out in our report. If we scan to help the surgeon, we need to point out in our report 3 things. Where is the nerve impinged? At what level? Is it impinged throughout the carpal tunnel or only in the entrance? Because it is very important for the surgeon. Sometimes we see that the nerve is impinged before the entrance of the tunnel, so proximally to the entrance. So here at this level, we see a huge nerve. That means it is very big, okay? So it is impinged. Where? At the entrance, at this level. But if we see that when we move distally, the nerve becomes very flat because it is impinged by the transverse ligament, okay? And at the exit of the tunnel, here, where the nerve becomes very flat and gives the branches and gives the motor branch, if we see here a very hypoechoic and huge nerve and a big motor branch, that means that the pressure is throughout the carpal tunnel. All the transverse ligament is pressing the nerve. We have to write it down in the report to make sure that the surgeon realizes that they have to operate and cut all the length of the transverse ligament. Because sometimes the surgeons are afraid to go far distally into the palm to cut the transverse ligament because they are afraid of the vascular arch. They are afraid to injure the vascular arch of the hand. That's why they are, let's say, afraid, and they are more confounded, and they don't go through the procedure to cut it all to the completely. Yes. So if this happens and the patient has pressure all along the carpal tunnel, even with the hypoechoic branches at the exit, it means that if they don't cut it all, we will end up with recurrent and persistent carpal tunnel syndrome. So we need to help the surgeon realize what type of operation they have to do. If they're not brave enough to do it, let somebody else do it for the sake of the patient. This is how I report. I report things that the surgeon likes to listen to. That's the only way that the surgeons take us into consideration, I mean the radiologists, and they take us seriously, and they like us, and they want us to help them. Yes, refer the patients to us, yes. So first is the nerve enlarged only on the entrance or also at the exit? That's the first question. The second question is the motor branch as expected? Is it at the radial side as it is in this person here? Or is the motor branch on the ulnar side? Or is the motor branch transversing the transverse ligament? Because that is important information. We need to help the surgeon not to cut it. And the other thing we have to tell him is about the palmar cutaneous branch. There is a branch that comes out like 6 or 7 centimeters proximally to the carpal tunnel. This is called palmar cutaneous branch. This is it here. You see here? Here. This is the nerve. And there's a tiny branch here. It goes away from the nerve and goes to the subcutaneous tissue. This branch is also important. It is called a cutaneous branch, and this cutaneous branch always comes out from the radial side, but sometimes it comes out from the ulnar side. And if it comes out from the ulnar side, it tends to go at the area of the incision of the surgeon. As you know, the surgeons, when they want to operate on the carpal tunnel, the surgeons make an incision here between the Guillon's canal and the nerve. Around this area, they operate around this area. This is the area of the incision line, okay? They go ulnarly to the nerve. So if this cutaneous branch is situated ulnarly, it is in risk to be cut by the incision. So that again creates paresthesias at the hypothenar, which are very bad complication of the carpal tunnel release, and it is a reason to reimburse the patient as well. So again, we have to tell them that the cutaneous branch exits at the radial side as expected. The motor branch exits at the radial side and doesn't go transligamentously as expected. The transverse ligament compresses the nerve only at the entrance or throughout the canal, and there is a huge nerve at the exit in the palm, and the branches are also big, and the motor branch is big. All this is information we have to put in our report to help the surgeon, because our role is to be on the side of the surgeon to help them produce a very good result of their surgery when it comes in nerves. That's our job. We are a friend to the surgeon. Yes. So this is the median nerve. This is the clinical anatomy of the median nerve. Now, there are a lot of other things that we can consider in median nerve. As we go up on the area of the forearm, you see here at the proximal part of the forearm, at the proximal part, you follow the nerve up, and you see that the nerve here, the proximal area of the forearm, is underneath the pronator muscle, and it is together with the ulnar artery. The median nerve is together with the ulnar artery, and then gradually the ulnar artery leaves. The ulnar artery leaves the median nerve. The median nerve is left on its own. The ulnar artery goes to find the ulnar nerve, and the median nerve goes more distally. Now, at this level, at the proximal level, the median nerve is found between the superficial and the deep, the flexor digitorum superficialis and the flexor digitorum profundis, so the superficial and the deep flexors of the fingers. And at this level also, it gives a little branch which is called anterior interosseous nerve. Usually, we're not able to look at this nerve with ultrasound because it's very, very small. But we know that this nerve is situated near the interosseous membrane. So here we have the two bones, ulna and radius, and here we have the interosseous membrane. So the nerve should be situated around this area. The trick to do is to put the Doppler. You find the little artery here, and you know that near the artery is this branch, the anterior interosseous nerve. So if you want to do a block or anything, you target there. Yes. We also have the pronator syndrome, which sometimes can be found at this area. Underneath the pronator muscle, the median nerve can be impinged by a big pronator muscle or by this very hyperechoic, let's say hyperechoic fibrous tissue. But again, we don't have a lot of findings in ultrasound. It is a clinical syndrome. We usually use it to perform diagnostic blocks. For example, if they suspect that there is pronator syndrome, they ask us, can you do a block at the area of the pronator muscle to check whether there is a pronator syndrome or not, and then we do it. We don't really see any findings. We just do it to help the clinical decision. Yeah? So I think that is it. If we go down first. Is it okay with you? Yes, you like?
Yeah, you make us realize that we still have a lot to learn.
No, the important, something else I need to say is how do we measure for carpal tunnel syndrome? That's important. So here when we want to measure, we measure at the entrance of the tunnel or at the area where we see the nerve bigger. And we measure it, we put zoom, how we put zoom? Okay, so we put zoom, we bring the nerve in the middle of the image, and then we use the cross-sectional tool to measure the cross-sectional area, and we measure inside the echogenic epineurium. This is the epineurium, the bright line, cross-sectional area, calipers, and then? Trace, good. So I put freeze because otherwise I cannot. How do you do it? Caliper, trace, okay. So we come here and we measure. We measure inside the echogenic epineurium, like that. Not the bright line, inside the bright line, okay? Here it is 11 square millimeters, which is totally normal. Up to 11 square millimeters, it is considered normal. Again, there are anatomical variations, there are anthropometric differences, and all of these should be taken into consideration. That's why we have 3 ways to do it. We check with the other hand. We create also the wrist to forearm ratio. So what we do here, we trace the nerve at the wrist, and then we move our probe proximally. We find the pronator quadratus muscle, which is this big muscle here, this flat muscle, This flat muscle is pronator quadratus, okay? And at this level, we trace the nerve again with the same way. The cross-sectional area trace and inside the echogenic epineurium. And we create the wrist to forearm ratio. So we create a ratio between them, and if the ratio is more than 1.4, the nerve at the wrist is enlarged. It is usually significant. You can also create the difference, so subtract one from the other, but it's not so much done in everyday practice. The wrist to forearm ratio is considered to be more accurate, let's say. So this is the way we do it. Now, if we have anatomical variations, which I'm sure you know of, we have the bifid median nerve, the trifid median nerve. Inside the carpal tunnel, so in this level, we are not allowed to see any vessels. So if we put a Doppler here, we are not allowed to see any vessels. Nothing, no vessels. If we see a vessel next to the nerve, this is an aberrant vessel or an anomalous vessel or an anatomical variation. And usually this vessel, which is called persistent stapedial artery, it is there up to 20% of individuals. It is quite common, and it can be combined with 2 nerves or 3 nerves. This is called the bifid nerve or trifid nerve. And sometimes you can have it without bifid or trifid, just a single nerve and the vessel next to it. This is an anatomical variation, which is quite common, up to 20% of individuals. So it's very, very common in everyday practice. Of course, it depends on geographical differences, but it's up to that. This is an interesting anatomical variation because you can have pathologies associated with it. So I think we can go on to the hands-on.
Yeah, so thank you, Professor Elena, and thank you, Professor Ahmed Abdelkhaliq, for your demonstration. And before we split into groups, just give me a second to thank the sponsors, Mindray